Hello and welcome to Patient-Centered GA Care, a synergistic approach to optimize management. I'm Dr. Stephen Ferrucci, Chief of Optometry at the Sepulveda VA Ambulatory Care Center in North Hills, California, and Professor at the Southern California College of Optometry at Marshall B. Ketchum University. I'm joined today by my friend and colleague, Dr. Mark Dunbar, Director of Optometry at the Bascom Palmer Eye Institute, University of Miami Health System in Miami, Florida. Welcome, Mark.
Hey, Steve. Thank you for having me. This should be a lot of fun.
You got it. Today, we will be discussing patient assessment and imaging modalities that help in the diagnosis of geographic atrophy secondary to age-related macular degeneration. So, Mark, as we know, early detection is key to preventing GA progression. So let's start by discussing the initial assessment of the patient who's at risk for GA. What questions are you asking the patient during the initial assessment?
Well, I don't really ask any questions in the initial assessment until I recognize the patient has macular degeneration. As you know, patients come in with blurred vision. They have trouble at night. They don't like to drive, and that's pretty non-specific for the most part in an elderly population. It can be from cataracts. It can be from any number of things. So it's not until you dilate a pupil that you look, and of course, as you know, Steve, macular degeneration is a pretty easy diagnosis to make. So the presence of drusen, the presence of RPE modeling, and that's probably going to prompt me to maybe dive in a little more deeper into, functionality of, how do you think you're seeing? Are you able to do things you like to do? Again, the diagnosis of macular degeneration is really pretty straightforward. Obviously the attention has been on geographic atrophy over the last year and a half. And so, quite honestly, I don't think any of us were really looking for geographic atrophy. So when we would see these patients with AMD, categorically, I try to decide, is it early, is it intermediate, or is it late AMD? We would do OCT scans and really looking, is there fluid? Has this patient really converted to wet, or do they have choroidal neovascular membrane, et cetera? And so, we really hadn't been looking for geographic atrophy. So that's something that, I think our focus has changed a little bit. I'm sure it's probably the same for you as well, right? I mean, again, it's the diagnosis of AMD is not difficult.
Right. Yeah. And, I mean, history is continuous throughout the exam, right? So you can ask people history questions towards the end or towards the beginning, but I think you're right. I think it's important to, ask about symptoms and that sort of stuff. One thing that we know from geographic atrophy is that perhaps best corrected vision is not the best measure of damage or symptoms of geographic atrophy. Do you ask, what specific symptoms do you sort of try to tease out of these patients?
Functionality, right? If they have good acuity, 20/20, 20/25, 20/30, we know that that doesn't always mean a lot. We're testing high contrast, white background, black letters, but it really is more functionality. Driving at night, being able to see subtitles. Our patients don't always cover one eye or the other eye. So you may find that vision may be worse in one eye than the other that they didn't even realize. Certainly, do they have any metamorphopsia, waviness? But I don't know that patients really volunteer that type of information. It really tends to be more trouble at night. I don't like to drive at night anymore. I have a hard time. Or, reading. I can read for 10 minutes and then it gets harder. And again, those aren't necessarily specific to AMD, but in the presence of typical AMD findings, then you try to match up what they're telling you with what you're seeing clinically. I know we harp on symptomatology a lot, but again, I think there isn't a specific hallmark symptom of a patient with macular degeneration or geographic atrophy, unless, of course, you're looking at more advanced disease, foveal, threatening, and now their acuity is down. And then, of course, that becomes a different game. But what I see our job is as the primary care optometrist is let's get these people while vision is still good, while they're still, in that good reading, good quality of life, good functionality perspective. Do you have specific questions that you ask?
Sort of, but like you say, a lot of the problems driving at night or decreased contrast sensitivity, stuff like that. Like a lot of older patients are going to have that, right? So they're not 100% specific for GA, but we do know that Snellen acuity patients have a lot of symptoms and their acuity can be, relatively good. So I would say don't rely on that.
Yeah, and I agree. In clinical trials, of course, they're going to read reading speed, they're going to do contrast sensitivity, those things that, I think are important when you're looking at treatments and really the effectiveness of treatments. But I think in clinical practice, I mean, all we really have is checking vision, distance, and near. Obviously, we may or may not do AMS or grid, and then our kind of clinical testing, speaks for itself.
Yeah, sure. What about risk factors? You talk a lot about, risk factors, smoking, et cetera, with your patients.
Yeah, that all the time, especially when you've made the diagnosis of macular degeneration. First thing, obviously, right? This is white, Anglo-European, certainly couldn't be Hispanics. We rarely see it in the African American population. So it's, genetics. And I don't think there's any other disease, besides macular degeneration where we have a really good understanding of the genetics of this disease. So, it's not necessarily what a patient did, it's really their lifetime, right? And it has to do with diet and smoking and again, genetic background. So we talk about those things. And, we're seeing less and less of these patients, in that geographic atrophy age group, AMD age group that are smokers anymore. It used to be much more common. So, or people have quit, but that's really one of the first things. You don't smoke, do you? Or if you smoke, you need to quit because that is really the number one risk factor. Family history to some degree, presence of GA or advanced disease in the fellow eye. I think all those are risk factors for gauging what's going to happen to, the fellow eye.
Yeah, 100%. And, a lot of studies kind of show that we as optometrists, as well as ophthalmologists, don't do a good job talking to patients about smoking in particular. And smoking, number one modifiable risk factor for AMD, GA. So I think it's uber important to have that discussion.
I would say, I mean, I think as optometrists, we do a pretty good job, but I think we are more into health and nutrition and lifestyle than, our retinal specialist colleagues who often don't take the time or don't have time. So I think it is within our wheelhouse, and it's a question I have quite frequently with patients in that age group.
Yeah, 100%. I mean, we're seeing the patients earlier where we can have that discussion. Sometimes our retinal specialists, by the time they see them, it might be too late to have these preventative discussions.
No question.
As far as diagnosis goes, what imaging technologies are you utilizing in your practice to look for geographic atrophy?
Well, again, traditionally in the AMD patient, it was probably 99% OCT, right? And again, it wasn't necessarily looking for GA. It was, looking, has this patient converted? And in this era of GA treatments, we know that fundus autofluorescence is really kind of blows it out of the ballpark in terms of recognizing it. It's been the benchmark in clinical trial designs and monitoring GA progression. So, I do a lot more autofluorescence than I did, only because, again, I'm looking for GA now. I've got a heightened sensitivity. Anytime I see drusen modeling, one of my questions is, does this patient have geographic atrophy as well? And again, I know you've had the same experience, right? You look back at some of these patients that you've been following with intermediate AMD, and now that you're looking for GA, you recognize these patients have had patches of geographic atrophy that we just didn't really pay attention to. So obviously, I still do a lot of OCT. That's primarily what I do, but I also now combine it in an AMD setting with fundus autofluorescence.
Yeah, I think that makes sense. And you're right. I mean, especially obviously color photos, if you have a late geographic lesion, I think it's pretty, apparent to see them, but certainly early lesions are frequently missed just on color photos. And especially if you also have a lot of drusen mixed in the mix, you can miss an early area of GA. So,
well, and I always say GA doesn't exist in a vacuum, right? It's not like they're going to have one thing or the other. A lot of times there's a lot of stuff going on. I mean, we've had tons of drusen, you've got modeling, and GA can get lost within everything going on. So, and then, you talked about fundus, photography, and, due to the economics, right? In a perfect world, I would get a photo and an OCT and autofluorescence. The problem is payers aren't going to pay for an OCT and a fundus photo. So you kind of pick and choose. If I'm going to do a lecture, it's a great teaching opportunity where, I will, then I'll do fundus photos. I like having a fundus photo. It obviously helps the patient understand what we're seeing. Again, it's a way, if you can spot the GA, it's another means of kind of monitoring progression, et cetera. So, but honestly, I don't always get it just because of the economics.
Yeah, no, that makes sense. But from a patient education standpoint, it certainly has some goals. And then on the OCT, obviously we want to look for that, that hypertransmission defect that we've sort of associated with geographic atrophy lesions, where you kind of get the light shining through more in the area of RPE atrophy. And that's, I wouldn't say diagnostic, but characteristic, if you will, of a geographic atrophy lesion.
And the problem is, again, in our mind, when we think of GA, it's that large, central or paracentral, area of GA. And so the problem is, obviously GA can get that way. I think, again, our goal is to catch it when it's outside. And so, if your line scan isn't happened to hit that area of GA again, you can miss it, which is why autofluorescence becomes so good, because you've got a snapshot of the whole posterior pole, and GA just highlights very well with those hyperfluorescent defects. Whereas, on a line scan on an OCT, you could theoretically miss it. So again, you've got to look at that near IR image as well. But it's not even only that, Steve. I mean, I think by now we've done a much better job of recognizing and looking for it. It's truly those biomarkers now that are predictive, whether it's predictive of conversion to wet or predictive of conversion to GA, the hyperreflective foci or the transmission defects, or the reflective columns that go down the reticular pseudodrusen. I mean, all those things now on an OCT, before I didn't really pay attention to or look for, and now I am, because we know it's a biomarker, it's a barometer for potential conversion.
Yeah, so certainly if we see these biomarkers, we're going to follow those patients perhaps a little more closely, counsel them perhaps a little more aggressively about not smoking or taking vitamins or whatever the case might be. But you're exactly right. And it used to be you just do an OCT. Is there fluid? Is there no fluid? But now we're realizing, there's other things in our AMD patients we need to look at to figure out who's at higher risk. So that's an excellent point. Do you think there's any challenges in making a diagnosis of geographic atrophy?
Yeah, I mean, just as we just said, right? There's a lot going on in a busy intermediate AMD patient, where you see, you can see hard drusen and soft drusen, and some of these drusen can coalesce. There's modeling, and then within that there can be small patches of GA. And so I think that's really the main thing that, before we didn't really look or care. Obviously, we didn't have a treatment for geographic atrophy. Now, because there are treatments, and we know that we want to try to, recognize them as soon as we can. This becomes almost like glaucoma doing a visual field. If it's outside, great, but monitoring progression. So, I just think the challenge is number one, within your mind when you're looking at an AMD patient's, asking yourself the question, is there GA? And I think your intent or purpose in your exam is specifically looking for that. Just like we would ask the question, do I see any fluid? Is there any elevation? Is there subretinal hemorrhage? Those are the questions as you're examining a retina macula that I think you have to ask yourself and then be able to answer, be it your clinical exam or your, multimodal imaging.
Yeah, no, 100%.
Again, 2 years ago, we weren't doing that.
Yeah, well, because we didn't have treatment, it was sort of irrelevant, but now it's relevant. So, switching gears a little bit, and thinking about geographic atrophy, when do you consider referring a patient to a retinal specialist with geographic atrophy for treatment?
Certainly any lesion that I kind of feel is threatening, within, fairly close proximity to the fovea, right? Whatever that is, if they're well outside the fovea, well, I shouldn't say the macula, but well outside the fovea, I'm probably not going to refer that. I'm going to obviously recognize it. Those patients I will see twice a year. I don't think I would bring them in more than twice a year, and follow them with probably autofluorescence and OCTs. And again, like the glaucoma patient, try to get a sense of, is this patient, what is their rate of progression? Anytime it looks like it's threatening the vision. And again, again, the idea, Steve, and you and I have talked about this a lot. It's GA isn't really a slow disease. I mean, relatively speaking, it is, but your window of opportunity may be a couple of years. So if it's going to declare itself and become a threat, right? And so I think you got to watch those patients quick. So if I thought it was a threat, I certainly would send it, fellow eye involvement, and now you've got the only eye. Certainly those patients I would send. I guess I would ask you, what about, once they've already lost central vision? I know I've heard some retinal specialists and our colleagues say they would treat because we want the scotoma to be smaller. I just think the burden of treatment is a lot, and so I'm not sure. I would refer those that have already lost central vision. What do you think?
I think that's a tough call because I think the concept of limiting their scotoma size might be good, but I'm not sure 100% how much that, really matters in day-to-day life. But at the same point, I think that with any patient with geographic atrophy, we have to have the discussion with the patient. We have to let them know that there is a treatment. If you don't feel that they're a good candidate for the treatment for whatever reason, you can explain that to them. But I think now with the treatments, the burden is on us as optometrists to at least have the discussion with our patients, offer it to our patients, and make the appropriate referral.
And at the end of the day, right, patients, especially at that level, sometimes need to hear it from the retinal specialist. I mean, obviously you can set it up and say, you know what, you've already lost central vision. I don't think you're going to be a candidate. I mean, you can talk about it. And again, there's got to be, some patients just want to hear it from the expert. And you're not always available, Steve. So I've got to send them someplace else.
So true, so true. Yeah, what kind of a discussion do you have with your retinal specialist if you're going to be sending them a patient over for treatment, or what kind of information do you try to supply to the retinal specialist if you're going to make this referral?
Yeah, well, I'm lucky because I'm in an integrated kind of health system. So, I work directly with some of the retinal specialists. So they have access. I have access to imaging and whatnot. So anytime I'm going to refer a patient, they will see it. But as you know, our retina docs, even if you did an OCT a week ago, or an autofluorescence, they're going to repeat it because that's just in their DNA. But, by the same token, right, we do have some retinal specialists that don't treat, that don't believe in it. So I think, one of the fundamental keys is determining in your community who are the retinal specialists that are going to treat. So I'm on Mondays, I'm at one of our satellites, and every other Monday I have it's split between two different retinal specialists. One definitely does not treat. And I've found out the hard way where early on I would send a patient and he was just very negative, didn't like it, didn't believe in it. And so, of course, it becomes a waste of the patient's time. The other one does treat. And so, in fact, they had seen one of my patients today who I had referred. The problem is the patient was starting to have some dementia, which, as you're looking at a much older population, and they just didn't feel that this patient was a good candidate. And the family didn't either, because, it's a every other month injection, and there is a burden of treatment on these patients at that age. And, you're relying on caregivers and family members to take them. So it may not always be a realistic expectation.
Yeah, no, 100%. I do think though, if you're sending to a, outside retinal specialist, sending them, especially if you can document progression over a period of time, right? If you as an optometrist have seen that progression, you can send them serial OCTs or something that shows that progression. I think that's super, super helpful.
And again, it sometimes may be the key piece of information that, makes a retinal specialist decide it should be treated. So I have no doubt about that.
100%. Any final thoughts or comments about geographic atrophy or diagnosing it? Or
well, yeah, I mean, I think we're still in the infancy of these treatments. I think we're really about a year and a half out from having the first treatment. Obviously, we've got some 2 to 3 year data that we are able to look, but I think it's going to be interesting as time goes on to really see, I think, the therapeutic benefit of both of these treatments for geographic atrophy. So, as I said, it's on my radar. I'm looking for it. And again, it's not like I'm seeing tons of GA every day. I mean, you see lots of AMD, but, over the last year, probably only a handful of GA. And again, between all of us collectively, I think that becomes a pretty big number. So again, if we can preserve vision for a lifetime for these patients, and again, get these patients to a retinal specialist before, it really has a significant impact of quality of life, I think we'll have done our job.
yeah, excellent. All excellent points. But thank you, Mark, for the excellent discussion. And thank you all for listening. Please remember to take the post-test and evaluation to receive CE credit and to tune in for additional episodes within the podcast series.